So, thanks very much, Yasser. So just by way of introduction to myself, my name's Matt Prime. I'm actually an orthopaedic surgeon, and it's not very common that orthopaedic surgeons do this type of research. So I'll just explain how I got to this process. I actually spent a year working as a surgeon in Malawi and became completely fascinated by, actually, Malawi as a country has an entire GDP of £1 billion. If you go to to Imperial College Healthcare, where I've spent a lot of time working, that hospital has a budget of £1 billion. And Malawi has a population of 15 million people. And I became fascinated about how you can deliver healthcare in that environment. So before I dive into what I've been researching, one of the things that we used to do there is, I mean, I don't know if anyone's been in an orthopaedic theatre, I suspect not, and if you have been, you're probably asleep, which is a good thing, is we use a lot of drills and a lot of power tools. A surgical drill costs $30,000 with its service contract, and that's because it can go through an autoclave. It is not appropriate in Malawi to spend $30,000 on a drill. And so what we did when we were in Malawi is we took a normal drill from B&Q, which costs £100, if that, and we put it in a bag, tied the bag up, and used that in surgery. And I just thought, this is crazy. Why are we spending all this money in the UK? When I put a screw in, so I've actually just been on call, when I put a nail in someone's broken leg, that nail can cost hundreds of pounds. The individual screws cost £50. They're barcoded, they're vacuum packed. I could go to B&Q now and buy 50 screws for 99p. So there's a huge price discrepancy. So I became fascinated by this topic, and so have ended up researching it for my PhD. And so the title of my talk is Frugal Innovations, specifically focused at healthcare. And I've been working at developing a toolkit to help identify frugal innovations, but grounded in empirical evidence, and looking at some of the dimensions that these innovations in healthcare are using to deliver the increased affordability, adaptability. So just by way of context, healthcare is facing significant future challenges, as I think we all know. In high-income countries, you're seeing aging populations, there's an increased burden of chronic disease, and there are exponential costs of healthcare delivery. £50 for a screw is not going to help us save money. In lower middle-income countries, you're seeing countries try to establish whole healthcare systems where previously care has been sporadic and of poor quality. To give you an idea, in Malawi, 15 million people, 5 orthopaedic surgeons, 4 of them in offices closer than this room. That is not spreading healthcare around the country. So a lot of this is just repeating a little bit of what Yasser said, so I apologise for that. But what we're seeing is innovators and entrepreneurs trying to shift the focus of innovation away from more is better to decreasing the cost of care and widening the access of care. And a lot of Yasser's research has been to try and empirically understand what we mean by frugal innovation. And as he said, it's about affordability, adaptability, and accessibility. So Yasser's described quite well, or very well, what frugal innovation is. I find it quite a difficult thing to try and explain academically. So if I can actually make this work. Is the mouse over here? Ooh. So this is the image that Yasser showed. This is the ECG machine. This is the Mac 400, or you'll see it in a minute. So this work is part of GE's program called Health Imagination. And this is about trying to understand what GE have been incredibly good at recognizing is that in the West, GE is targeting a market of America and Northern Europe. That's 1 billion people. There are 1.3 billion people in India and 1.5 billion people in China. So potentially your market could go up 4 times if you can create products that can satisfy Indian and emerging markets. So they changed their whole focus at the start of this century, and they've really created R&D labs grounded in, well, this one comes from an R&D lab in Bangalore. So to tell you a bit more about this product, as you can see, they've stripped out all the buttons, all of the screens. And the printout read that you see there is actually from a bus ticket. So when you get on the bus and you press, it gives you your bus ticket. I mean, we don't. We put our credit card on it. But that is where that comes from. That's where the idea came from. And they decreased the cost of that to about $800. So that delivers an ECG for about $1 per person. To date, and this is data that's 2 years old, to date, that product, how much do you think that's raised in terms of revenue for GE? $275 million. And that's because their market potential is massive, because now they're not just looking at St Mary's and Mass Gen for an ECG machine, they're looking at every rural clinic in India. So it's huge for them, and it's been a real refocusing of the way that their company is delivering healthcare products. So let me continue. So my idea was, we know a lot about the Mac 400. It's all over business press, and that is that's deliberate from GE because it's marketing. So my question is, well, one of my questions is, how can we identify new frugal innovations for healthcare that we're not seeing all over The Economist and Harvard Business Review? And I also wanted to understand a bit more about what it is that they're doing that allows them to deliver frugality. So innovations are really messy to research. It's quite hard to understand how you're going to position your question. So I pursue an emergent mixed methods research strategy. And for this study, the primary purpose was to try and identify new frugal innovations, and the secondary purpose was to understand how they were doing that. So I did a pilot study to develop a tool based on YASA's empirical research, and then we did a larger study to test the identification tool to see if in a cohort of generic healthcare innovations we could actually find ones that were frugal. A lot of this is based on qualitative data collection strategies, and the reason we use qualitative data is because you can get a deeper contextual understanding of the innovations which you're trying to study, because you're learning about them applied in real life scenarios. So, but I also wanted to try and test the tool, so quantitatively look at inter-observer agreement for how the tool was applied by one person compared to another, and then using the field notes that we collected for our interviews, I've done a thematic analysis to try and pick out the core themes within that of what these innovations are doing. So I'm not going to talk too much about the pilot phase because it's not that interesting, but this was the tool that we developed, and then we took that. Unfortunately, we were able to go to Doha, to the World Innovation Summit for Health, which had 28 generic healthcare innovations. If you put innovation into, I mean, it's so difficult to know where you start in terms of where would you even study innovation. But fortunately, we were able to attend this summit where there were 28 exhibitors of new ideas of healthcare innovations. And they represented a broad range of healthcare products, processes and services, which gave us quite a nice cohort. And Yasser and I independently interviewed all of the innovators there, and everyone was consented appropriately. So these are just give you an idea of some of our results. So over 2 days, we interviewed 90 innovators, and we did about 56 interviews with 90 innovators. So Yasser interviewed them once, and I interviewed them once, and that was about 20 minutes per innovation and about 20 hours of interviews. And overall, we agreed in 20 of 28 assessments of these innovations, and that was a proportion of agreement of over 70%, and gave us a Cohen's kappa of 0.4. And we identified 13 that we thought were frugal, 3 that we didn't think were frugal, and 4 was unclear. And the reason for unclear is that innovations are presented in all phases of their kind of existence, and some of them is just you don't know what they're going to be, whether they're going to be an innovation that could be classified as frugal, or whether it's all about making money, and they haven't really thought through what their ideas are going to be. And 8 of them, Yasser and I disagreed, and we then went away and discussed them. And so we had this cohort at the end of 15 frugal innovations. And these are them. So I'll just expand a little bit on each one. So one is the Arbitus drill cover. That's the drill cover that was so the work we did with the bag in Malawi was actually picked up by a university group in the University of British Columbia and turned into a product that they now try and market and sell. E-Access is about remote connecting intensive care units. Fosmomed is about reverse osmosis to develop IV fluids. Jammar is a birthing kit for people giving birth in rural villages. Miraculous is a cheap way of looking at microRNA. Mother's delivery kit similar to Jammar. Peak Vision you've heard a little bit about, and I'm going to show you a video of that. Possible is a hub and spoke model for care in Nepal. Promuja is actually a microfinance initiative or innovation which has been established for a long time, but what they've done is piggybacked healthcare insurance onto their model, and they've done it in a very clever way. Pamani is a CPAP device for children, which has been developed very much along the methodology of the ECG machine. Actually, all of the stuff to repair it comes within the shell of the device. So if it breaks, they can fix it there and then. RoboHand are 3D printed prosthetics. Smile Train is a process innovation around delivering care for children with cleft lip and palate. Zikitsa is actually an ambulance innovation, and it was developed initially in India, and it's a tiered pricing strategy. So if they picked you up and you were going to a private hospital, you would pay this, and if you were going to a state hospital, you would pay this. And the people going to the private hospital know that they're subsidising the people going to the kind of state hospitals, and they're happy to do that. And actually, the people going to the private hospitals pay less than they would if they'd ordered a private ambulance. The Smart Ear is a hearing device, and Sugarvasu Healthcare is a way of delivering primary care in India through Indian traditional healers. So I'm not going to go through the other ones, that's just to give you a rundown on those. But I thought I'd show you this video of Peak Vision. I know Yasser's shown some of the images, but it gives you an idea of what they're doing. It's a shame you can't really hear them speak. Turn the volume up.
We believe 80% of that is avoidable.
Peak is a portable eye examination kit.
You have to put this down.
To mobilize the eye clinic. Every part has been designed with the non-specialist
Oh. I will give up on that. I'll just describe it. So this is a group that's actually based at the London School of Tropical Medicine, or they were. They've actually just spun out as a startup. And it's founded by a group of ophthalmology registrars. And Andrew, who's the kind of co-founder, was doing his PhD in Kenya, and he was studying a cohort of 1,000 patients. And he was driving around in a Land Rover with all of the kit that you see in this. And he just thought, this is bonkers. I can't get anywhere. When I get anywhere, I can't plug any of these devices in. And he just had a brainwave to try and put it all on his smartphone. So over the last 6 years, they've developed these tools. So it's not just a kind of the ophthalmoscope. It's actually the all of the other tests that come along with it. So testing for colour blindness, testing for visual acuity, and also ophthalmoscopy. I'm particularly relieved. I don't know if anyone's ever done an eye exam, but I'm very right-eyed. So if I'm trying to examine someone's left eye, I end up nearly kissing them, which is always a bit awkward.
The retina adapter is the most exciting device I've ever designed. It is incredibly simple, and yet it will change the way we look at eyes.
The moment the retina filled the screen...
That is literally just held over the eye.
...was the most defining moment of my career.
It's an amazing thing that you can do with a phone.
One of the tests, one of the experiments they've done with this was to see what the image capture was like with people with 1 day's training versus consultant ophthalmologists. And they've published this, and I can't remember which journal, but what they showed was that the image capture by someone with 1 day's training is as good as a consultant ophthalmologist. And what they then next did was say, well, why don't we give this to the head teacher? And they did a trial in Botswana. So they gave it to the head teacher of the primary school, and he did the eye tests. The images are sent, because this is digital now, it's captured, it's sent over their platform to the eye hospital in Gaborone in Botswana. The eye ophthalmology consultant can look at the image there, make a diagnosis, and if they need to come, he can send a text message back to the head teacher, back to the parents of the child, and say, you need to come, and we're going to schedule you on this date. And if they don't come, a text message goes back to the head teacher going, they haven't turned up, can you explain why? And one of the things you don't hear on the sound is actually what they say in this is that all the ophthalmologists are concentrated in the towns and city centres. And they don't go out to the rural villages, yet 70% of the population live in the rural villages. So they're really, through this digital platform, through the platform on the cloud, they can really massively access wider communities and hugely decrease the cost of care, and also store the image for the purposes of kind of long-standing evaluation. So I went through all of the field notes and did a thematic analysis, and these are some of the key things that I was seeing. And I mean, these are very much originating, so they're not refined in any way at the moment. This is just where I think I'm at with them. Clearly, information communication technology is key, not just in its terms of what it can do, but the platforms that are associated with it allow for this idea of accessibility. The other technologies here really relates to 3D technology. And again, the 3D technology, RoboHand, which is not the most slick name, but it's a really interesting guy based in South Africa who was a mechanic. And he had an accident at work and he lost 3 of his fingers. And he couldn't get into the hospital in South Africa to get these what he wanted, because they said, well, we don't really make those. So he made his own 3D printed prostheses, and then from that has built the whole business up doing prostheses for anyone who's had an amputation of some format. All of his designs are open sourced, so anyone can use them. And he's got these big 3D printing workshops now in South Africa, and he just prints the designs. But theoretically, the design could be in the Congo, it could be in Egypt, it could be in Chile, and they could just print the designs. So that will hugely decrease the cost of prosthetics. We saw a lot of simplification of the GE and the GE Mac 400 philosophy. Some of the other ones that were really interested were about task shifting and harnessing existing networks. So task shifting, if you think about what the Indian traditional healer is doing, they're not practicing the medicine that I've learned, but using protocol-driven care, they're able to leverage the trust that the Indian community has in that Indian traditional healer, and also leverage the fact that they're actually in the communities to deliver some form of primary care. And harnessing existing networks was a common theme. So Promuja has this kind of big microfinance network, and they were able to harness that network to deliver healthcare. Again, the Indian traditional healers are harnessing an existing network. And various other things like tiered pricing, which we came with the ambulances, and cross-subsidization. So actually, Yasser put up a slide of the Aravind eye care model. Quite a lot of people may have heard of this. This is where you do this kind of production line of cataract surgery. They don't make any money by charging people for cataract surgery at Aravind. They've been doing this for about 40 years. And where they make their money is that when they started doing it originally, they thought that the cataracts that they were putting in were really poor quality. So Aravind is now the biggest supplier of cataracts in the world, of the lenses. And they use that as a cross-subsidization model to finance their other activities of actually delivering care. So this just shows a little bit how they map over each other, and you can see how ICT technology is pretty critical in this. And again, these are still emerging. These are still kind of my ideas for how I think these things are working together. And one of the things I really want to do is look at the different innovations and how they link. So simplification and portability, where are the linkages? So in conclusion, I think that we've created a tool, a strategy that helps identify these frugal innovations, which takes it away from being a marketing tool for companies. And some of these high order codes just represent different dimensions that innovators looking to do something can use to try and create interesting products. I mean, everyone must have heard of, everyone's tagline at the moment in developing something is, I'm going to create the Uber of healthcare. What someone should do is use Uber as an existing network and deliver healthcare through Uber. And that would be harnessing an existing network. So anyway, thank you very much for listening to what I've got to say. It's still emerging kind of work. I'm interested to have any feedback. And I'm going to hand over to Matt, who's going to talk you through one of the other things that we look at.